Good morning, everyone. I'm really honored to be here. It means a lot to be participating in this conference, having had several patients over the course, mostly of my training, who taught me a lot about these disorders. I will be presenting no hard data. I will be presenting no arrows. I have nothing concrete to go with when it comes to my subject here. A few caveats about me. Number one, I'm an unabashed pediatrician. So one of my fellows always puts this onto her slides, and so I figured it seemed fitting. I'm also very particular about details, and I'll point out that that's not an anatomically correct lung on that pillow. So I'm going to be presenting two patients initially. Patient one, an 11-year-old who comes in with a cough, and I always think about past history. She'd been born on time and carried a diagnosis of asthma, which had been well controlled. Patient two is 8 years old, also comes in with a cough, also had been born on time, and doesn't technically have a diagnosis of asthma, but as I go through the history, probably had asthma at some point in the past, might still have a little wheezing. Both patients have a dry cough. There's a little bit of extra information on patient one. She had some fatigue with her symptoms and eventually coughed up a small amount of blood, which was actually attributed to just coughing a lot and causing some irritation. Not completely inconceivable. Patient one had symptoms for about 3 months before she went to the emergency room. Patient two only had symptoms for 5 days, but a pediatrician had gotten an X-ray, and she went to the ER. Both of them have pleural and pericardial effusions. Both of them ended up with central lines in their left arms, so these X-rays are remarkably similar. In patient one, you'll see a lot of things that came up in the radiology discussions yesterday. You can kind of just see increased markings all the way through the lungs, these sort of thick white areas where the lung tissue itself is thicker than it's supposed to be. She also has a little bit of fluid around her heart. Her mediastinum is big. Patient two, also a little bit of increased markings, those sort of white areas that go out, and she has some fluid in her left chest. CT scans from both patients are in some ways rather similar, and I picked early CT scans from the course of patient one. Again, there's the lung tissue itself has some extra fluid in it. There's some fluid in between the different lobes of the lung. This really won't show up well. There's a little bit of fluid around the lungs. In patient two, towards the bottom, in the left lung, so it's going to be all the way on the far right side, there's a little bit of fluid around the lung. They actually both came in with fairly similar lung function tests when they first presented. So patient one had a mixed picture, meaning there's two different things going on. So she had restrictions. The lungs look small, at about 60% of what we would predict for her age and size. She also had some obstruction, and that responded to albuterol, so kind of looks like asthma on top of everything else. Patient two, restricted, small lungs, just about the same values, around 60% of what we would predict. She had a little hint of obstruction, maybe responded to albuterol, but there was some technique thrown in there. But again, maybe a little bit of this sort of asthma-like behavior. I have MRI images from both patients. I'm giving you a very selected discussion of what grabbed my attention. I'll do patient two first. The bright white line going straight down is her thoracic duct. There's a little bit of bony involvement. You can see one of the vertebrae from her spine that's bright white. And I put this picture up right where the trachea, the main airway, divides into the right and left lungs, and there's some areas of, it's sort of white around the airways. So there's that fluid that's around the airways. In patient one, you can actually see her airway going all the way down through her chest and dividing into the right and left lungs. In her case, the fluid isn't just around the airway, it's actually, her disease was in the airway itself, and I'll show you a little bit more of that later. As far as what happened with these patients, patient one got a biopsy. There was bloody fluid as soon as they entered the chest, but no vessel that was bleeding. So she's got bloody fluid, and patient 2 just had chylous fluid. Patient 1 was intubated for quite a number of weeks with her chest tube putting out a lot of fluid. Patient 2 wasn't intubated as long, but again had a chest tube for a long time, as well as a drain around her heart draining fluid. Based on the bloody fluid, patient 1 had KLA. Patient 2 is CCLA versus GLA versus GSD. The fun fact about patient 2 is I just saw her within the last week. Her workup is not entirely done yet, so we're not quite sure where she's going to fall in all of this. She's on sirolimus and has an upcoming lymphangiogram, and I'm going to spend the rest of my talk really focusing on patient 1 because I've got so much more on her. So here's some more MRI images. It's fun to me to be able to present MRI images of the chest and people aren't completely confused. Any other audience would say, why would you ever MRI the chest? The short version is, unless you're doing kind of innovative research protocols, the lungs do not show up on an MRI. So if you can see them, they're sick. So the image on your left, you've got an image looking straight ahead at her, and you can see that one of the lungs is compressed by a lot of fluid, that white area around the lung, and then the other lung, you can see it really well. It's because there's disease within the lung itself. On your right, this is again one of these cuts axially, so going through the chest like this. And not only is there fluid around the lung, but this again points out there's all sorts of involvement of disease around the heart, all through the mediastinum, the central parts of the chest. And you can actually see airways all the way through here, all of these little rings that are highlighted. Those are airways with disease in them. If we look at just a CT scan, because at least most doctors looking at chests are going to be much more used to seeing CT scans, there's a lot of fluid around the left lung. But especially in the image on your right, there's a lot of disease within the lungs themselves. And the term interstitial lung disease came up yesterday. That's a broad term that basically just means the lung tissue itself is sick. And clearly in this case, you've got areas where the divisions within the lung that should be fine and delicate are thick. The lungs themselves are sick. I'm now going to try to do a 5-second primer in bronchoscopy. This is a normal bronchoscopy. So on your left, you've got the bottom of the windpipe, bottom of the trachea, dividing into the left lung and right lung. Left is left, right is right, and that's what it should look like. The picture on your right is a little further out into airways, and basically airways should be clean. There should not be a lot of mucus. Everything should be really sharp where everything divides. That's what healthy lungs look like. So I actually have some pictures from inside of patient 1 where we did a bronchoscopy. So these are both pictures looking where she divides into the right and left lung. I have never seen a surface of an airway that looks like this, where it's disease within the tissue itself lining the airway. If you touched it, it bled. It was very, very fragile. And it's maybe a little bit hard to appreciate, but the back wall of the trachea, so on the bottom, every time she would breathe, she would be trying to squeeze air out, and the back wall would bulge in a little bit, which I'm trying to show on that picture on the right. She's under anesthesia at this point, and even in that setting, she's working to get air out. It's almost like watching asthma in real time. The other thing that we saw in her airways was lots of mucus. It was very thick, and it doesn't show up great up there. It's almost a little bit yellowish, greenish. I think there was chylous fluid within her airways, not just around, but really within her lungs themselves. The thing that really got my attention about patient 1, and the real reason I wanted to go through her, is because she ended up having multiple different issues that a pulmonologist could be involved with, as opposed to a single process that sums everything up. So the first thing for her was she had progressively worsening lung function. So her lung function tests got worse over time. The last lung function tests we were able to get on her had values 20 to 30% predicted, and then afterwards she was actually just too sick to be able to do lung function testing. Over time, she needed more and more oxygen. She also needed more and more help with her breathing, and in fact was on BiPAP, so a machine that gives you pressure to help you breathe, but you use a mask instead of being on a ventilator with a breathing tube. I also pointed out she was much sicker when she had fevers. For a pulmonologist, this is exactly what we expect. If you're on oxygen and you get a fever, you're going to need more oxygen. If you're on BiPAP and you get a fever, you may need more BiPAP. Fevers are just a challenge on the body, so anytime you get a fever, we're going to have to work harder to help you. So that's just part one of her, is her lung function, needing oxygen, and needing help breathing. Part two, she had very severe but reversible airway obstruction. So we had her on all kinds of asthma medicines. We had her on a high dose of a controller inhaler. She was completely dependent on rescue inhalers. So the medicines that we, tell someone with asthma, use this only if you're having trouble, we could not use them. Every single day, at best, she needed them 3 times a day or every 8 hours. Sometimes she needed them every 1 to 2 hours. And she was completely dependent on steroids. If she got the tiniest bit of a cold, she needed extra steroids. And if we tried to wean steroids off, because she was on steroids for her KLA, even if we thought from a KLA standpoint, maybe we can get the steroids down, her breathing problems will get worse. So this is the second piece of her. She's behaving like asthma, but really bad asthma. The third piece, she was very sensitive to fluids and needed medicines to help decrease the amount of fluids in her lungs. And then the fourth piece was all of that mucus that we saw in her lungs. She had trouble coughing it up. So we actually had to use treatments to help her clear mucus. So if I were summing her up for a room full of pulmonologists, I would describe 4 different processes, all of which were happening in the same patient. What I'd call chronic respiratory failure. She's got functionally small lungs that are being compressed. She's got hypoxemia. She needs extra oxygen. She's also behaving like severe asthma. She also has fluid overload and needs medicines to help get fluid out. And she has trouble clearing mucus out of her airways. So 4 different things, all of which we were helping to manage. Now, here's the problem as a pulmonologist with these kinds of cases. People always say, if you hear hoofbeats, think horses, not zebras. So I should never think KLA, GLA, GSD the first time a patient walks into my office with a cough, or for that matter, difficulty breathing, or even a pleural effusion. That's not where my mind should go, because there are many other disorders that are going to be much more common. So I asked the question, do we learn about these disorders? So I took a quick look through the preeminent textbook on pediatric lung diseases, which is, about yay thick, and it's typical textbook of really thin pages. So I accessed it online, so I don't actually have the page count. But 800 some odd page textbook or something. This is the entirety of what's in there on the subject for a pediatric pulmonologist, covering lymphangioma, lymphangiomatosis, and Gorham-Stout disease. Really doesn't talk anything about real symptoms. It mentions sirolimus once. The thing that did get my attention is at the very end, and I put this in bold, the LGDA Alliance and your website is actually in the textbook. So that actually made me very happy. But this is the entirety in the master textbook on my discipline. So then the next question is, well, am I supposed to know about these disorders even if it's not really in the textbook? So I took a quick look at the content specifications. So this is what the American Board of Pediatrics says a pediatric pulmonologist is expected to know. It's 134 pages with 4 pages of introduction. So 130 pages of bullet points. And there are no bullet points of lymphangioma, lymphangiomatosis, lymphatic anomalies, or lymphatic malformations. If you search lymph, you get mostly hits on lymphocytes, which are important cells, and a brief mention that the flow of lymph within the lung should be in one direction only, which is out of the lung. So again, sort of summarizing from my standpoint these disorders, what are the pulmonary signs and symptoms of GLA, GSD, KLA? What might I see? So cough, commonly mentioned. Shortness of breath and respiratory distress, and those came up yesterday in the sort of, presenting symptoms of GLA and KLA. All of these are in blue because this sounds an awful lot like asthma, so any of these things that I see, that's where my mind should be going first. Effusions, certainly not normal, but there are many, many more common causes of effusions than any of these disorders. A plain old pneumonia can cause a very impressive effusion. These are completely non-specific symptoms and signs. If you walk in with all of these, I'm not going to be able to tell you what you have. And odds are, it's not one of the disorders that we're talking about. But this really does matter when it comes to these diseases. So we've seen a little bit of survival curve data yesterday. This is another set of survival curve data, specifically looking at KLA, where in black are first symptoms, blue are first respiratory symptoms, and in red, the diagnosis of the lymphatic anomaly. And so the easiest way, I think, to look at this is, say, go on the y-axis vertically to 50% survival. And if you look at where the first respiratory symptoms are, your 50% survival is close to 6 years. Again, population average, some people go much longer than that, others die sooner. But 5 to 6 years from first respiratory symptoms, if you look at that red curve, where the diagnosis was actually made, you're closer to 3 years. So this just sort of speaks to the very long delay in diagnosis in a lot of these disorders, which a lot of you here are very familiar with. You're not going to get a diagnosis immediately unless you happen to have never had symptoms, rapidly show up in an emergency room, coincidentally have a radiologist in an emergency room who is collaborating with a vascular anomalies team and say, hey, this looks exactly like what I treat. That's not the typical experience. So what's actually in my toolkit to treat these disorders? And there's a lot of jokes of pediatric pulmonologists basically have inhalers, steroids, and antibiotics, and that's it. So what do I have? I actually do have inhalers. And I have to put in a plug-in. Your inhaler works best with a spacer, even if you're an adult. I do have steroids. And I do have antibiotics, and I love this picture. Antibiotic, 250 milligrams. Okay. So that's my basic toolkit. I do have a few other things. So I talked about airway clearance issues, thick mucus. I do have a couple of different devices that I can use. I am not endorsing anything here, but these are the main products that are available, either percussive vests or handheld devices that help patients get mucus out. Also in my toolkit are machines to help people breathe. Obviously, there are ventilators in intensive care units where you need a breathing tube, but times have changed over the last few decades. There's more and more ability to give support for breathing without a breathing tube. So on the left is a plain old BiPAP machine, which you might use for sleep apnea, but you also can use for someone who, when they're asleep, needs a little extra support. On the right is a somewhat fancier device which can function as a BiPAP or can function as a full ventilator and can support our patients. So my role in these disorders, because we've heard from a lot of other providers so far talking about the lungs and in many cases effectively treating the problems in the lungs. So what's my role? So I'm not a surgeon. I don't play one on TV, unlike all the people in that photo from Grey's Anatomy who did play ones on TV and probably made great money doing it. I'm not an interventional radiologist. I have no ability to do lymphangiograms or anything invasive like that. And for that matter, my toolkit does not even really include most of the medications that are used in these disorders to actually try to treat the the underlying process. So sirolimus, bisphosphonates, these are not within my wheelhouse. I do have the ability to do diagnostic testing, so lung function tests, and for that matter, I can do bronchoscopies and get samples if needed. I can do a lot of treatment. It's really supportive and symptomatic. I'm not changing the underlying process, but I certainly can help patients hopefully feel better. I have medications. If the physiology is right, if you're behaving like asthma, I can treat that. I can help with mucus clearance and getting mucus out of the lungs. And I can help with respiratory support, with oxygen, with BiPAP, or non-invasive ventilators. And I have two other roles, which frankly are the most important ones to me. Number one is learning from my patients, and the entire reason I'm here is from patient one. I was a fellow when I took care of her. I was still in training, and I saw her more than any other pulmonologist in the hospital did. And she taught me a lot of things, including the ability for someone to be in respiratory failure, on BiPAP 24 hours a day, still eating, even though we say you're not supposed to, complaining about the food and giving me a 40-minute long complaint about how you couldn't get good sushi in Cincinnati. But she was the character. And my other role is working with a wonderful team. This is only a subset of our team in Texas Children's, but it's one of the best parts of doing this. So thank you all very much.
So thank you very much. I'm going to ask the speakers from the morning to come up and have a seat.